Hemodialysis is the most common renal replacement therapy used with end-stage kidney disease and renal failure. It involves passing the client's blood through an artificial semi-permeable membrane to perform the functions of an otherwise healthy kidney, such as filtering and excretion of toxins. It is also a means of correcting fluid and electrolyte imbalances. It is started when the client's uremia can no longer be treated adequately via conservative medical management. Other complications leading to immediate dialysis include encephalopathy, neuropathies, uncontrolled hyperkalemia, pericarditis, and accelerated hypertension. There are two methods of dialysis available. Today, we'll discuss hemodialysis. To perform hemodialysis, a very rapid blood flow is required as well as access to a large blood vessel. There are three different ways in which access can be gained. These include arteriovenous fistulas, or AVFs, arteriovenous grafts, or AVGs, and temporary vascular access. AVFs are placed subcutaneously and usually located in the upper arm or forearm with an anastomosis between artery and vein, usually the cephalic and basilic. Due to the high volume and high pressure, the vein becomes arterialized with a larger caliber and thicker walls. AVFs should be placed at least 3 months before the need to initiate hemodialysis, and maturation time of the arterialized vein can take 6 weeks to months. Normally, when palpating the area of anastomosis, a thrill can be felt. You will also be able to auscultate a bruit or a swishing sound with your stethoscope. This is because of the high velocity of arterial blood flow through the vein. For patients with history of severe peripheral vascular disease or those with a prolonged use of IV drugs, AVFs are more difficult to create and a synthetic graft may be required. Grafts, or arteriovenous grafts, form a bridge between the veins and arterial blood supply. They are surgically anastomosed, usually between the brachial artery and the antecubital vein, underneath the skin. Healing time takes place in 2 to 4 weeks, but in some cases it is used sooner. The artificial materials used to create a graft, however, makes it more susceptible to infections than the AVF. They also have more of a tendency to become thrombolytic. If infection does occur, being that it is difficult to completely resolve, surgical removal may be required. There are several risks concerning surgical creation of arteriovenous access for hemodialysis. Development of distal ischemia, also referred to as Still syndrome, and pain because too much of the arterial blood being shunted or stolen, hence the term Still syndrome, from the distal extremities can occur. Clinical manifestations include pain distal to the access site, numbness or tingling of the fingers, which may increase during dialysis, and poor capillary refill. Clients are also at risk for developing aneurysms, which can rupture if left untreated. When dealing with clients that have vascular access, it is imperative that they be placed on precautions. Blood pressures, placement of IV lines, and venipuncture are restricted in extremities with vascular access to prevent infection and clotting. When immediate access is required, temporary vascular access is achieved by catheterization of the internal jugular or femoral vein using a flexible catheter made of either silicone, Teflon, or polyurethane. This procedure is done non-surgically and performed at the bedside. The catheter usually consists of a double lumen with an internal septum separating the two internal segments. One lumen is used for blood removal while the other is used for blood return. Recommendations are that clients remain hospitalized while temporary catheters are in place due to the high rates of infection, dislodgement, and malfunction of these devices. Temporary access can also be achieved through the use of long-term cuffed hemodialysis catheters. These catheters provide temporary vascular access while the client awaits fistula placement, or can also be used for long-term access when other types of access have failed. Placement is on the upper chest wall and is tunneled subcutaneously to the internal or external jugular vein. The tip of the catheter is placed in the right atrium. It has two subcutaneous Dacron cuffs, which prevent infection from traveling along the catheter and also anchors it in place. The dialyzer cartridge is made up of thousands of parallel hollow tubes or fibers. Blood is pumped through the top of the cartridge and pours into all the fibers. Dialysate, or the dialysis fluid, is introduced into the bottom cartridge and bathes the fibers. During this process, ultrafiltration, diffusion, and osmosis take place across the pores of the semipermeable membrane. Once the blood has been filtered through, it comes together into a single tube, returning to the client. Large bore needles, typically 14 to 16 gauge, are inserted into the fistula or graft to gain access using tubing to dialysis lines. One needle is used to pull blood out of the circulation to the hemodialysis machine, while the other is used to return the filtered blood back to the client. If a catheter is used, the two blood lines are then attached to the lumens. The red catheter, the needle closest to the fistula, is the one used to pull the blood from circulation and into the machine, assisted by a pump. Heparin is also added to the blood as it travels through the dialyzer to prevent any clotting that may occur due to the blood making contact with foreign substances. A dialysate deliverer and monitoring system is used to pump the fluid through the dialysis machine, countercurrent to the flow of the blood. The procedure is finished by flushing the system with a saline solution to return blood into the extracorporeal circuit back to the client via the vascular access. Once the needles have been removed from the access lines, firm pressure is then applied. Pressure is held there in place until the bleeding stops. Before beginning treatment, complete an assessment. Previous post-dialysis weight and the present weight determine ultrafiltration or amount of weight to be removed in fluid. Vital signs are taken every 30 to 60 minutes due to rapid blood pressure changes. 3 to 4 hours, 3 days a week is the schedule for most clients seen in outpatient centers. Other options include short daily and nightly hemodialysis, which is done at home depending on family support available to the client. The length of time for these procedures are typically 2.5 to 3 hours, and it is done 5 to 6 days a week. Thank you so much for watching, and this concludes my presentation on hemodialysis. I hope that the information was helpful to you.